Hello again. I am Dr. Robin De Leon, a physical medicine rehabilitation specialist. All right, I was a combat medic at the start of my career, became an emergency medical technician in New York City. I actually became a doctor and became the EMT course director for a few years out of Fort Campbell. All right, I in my career taught medics, medical students, residents, primary care residents, nurse practitioners, and so this is a series of lectures I'm putting out on different topics. We're starting with vital signs. The prior one I did was pulse. Today's respirations. It's going to be a little more complicated, all right, in terms of the details. So a couple of early teaching points to pay attention as we go through. All right, here are some critical issues that come up we're going to think about, and that helps us understand when we're taking respiratory rate on somebody, how to interpret it, all right? Because that's the key. It's not just knowing how to sit there with the watch and go, okay, I'm counting how many times your chest moves, or I'm listening to stethoscope how many times your chest moves, but what does that number mean when you're done counting? And that's the key. You're taking it for a reason, so what do we want to know? So everything starts with, what is the most sensitive organ to continuous nutrient flow, oxygenation, whatever? And the answer is the brain. And how long does it take before the brain notices there's a problem with you not breathing or breathing improperly or whatever? Well, if we remember what we've all experienced, if I squat down and then I'm here working on something and I go to get up, sometimes my blood vessels stay dilated, blood pools in my leg, I get less blood back to my heart, and for one heartbeat, I am squeezing an empty chamber. And so for that one heartbeat, there's nothing hitting my brain, and my brain goes, I don't like this. So it instantaneously knows. So that's where you look. If the brain is doing fine, we're doing okay at the moment. And then you can look at the rest of the patient and look at the breathing in that context. But if the brain is not doing fine, then how you interpret that breathing suddenly becomes a big deal. All right? So the brain is where you look. What is the mental status? What is their level of consciousness, their level of alertness, their own sense of, hey, I feel like I can't breathe, I feel like I'm going to die, things like that. You know, they're telling you right off the bat, I've got a problem, and you better interpret those things quicker. All right, those settings. So, why do we breathe? There are two reasons why you breathe. All right, and the only two reasons we go to the ventilator and make changes is we're doing the breathing for you. All right, so when we breathe in, diaphragm contracts downwards, intercostal muscles pull our chest cage upwards. That creates a larger chest capacity, the same volume of air inside of it, larger space, means pressure drops, nature abhors the vacuum. Air is going to rush in through the easiest hole, ideally that's your mouth and nose, down into your lungs, fills your lungs, equalizes pressure, and so you're breathing in to get oxygen. Oxygen in. All right? Then you relax your muscles, your diaphragm comes up, intercostal muscles relax, your chest cage comes down, you have a fixed amount of air, you now crush down the space, that increases pressure, all right? Normal pressure outside, high pressure inside, nature abhors the vacuum, pressure wants to equalize, it's gonna go out the easiest hole, ideally that's your mouth and nose, and you exhale. So in the process of exhaling, what are you getting rid of? CO2 out. Those are the only two reasons you breathe. To get oxygen in and CO2 out. All right? Now, interesting thing, and we're going to get into the details of this in a moment, but I may only need to breathe 8 times a minute to get all the oxygen I need. But a lot of us have heard you got a CO2 drive, but I may need to breathe 12 times a minute to get out the right amount of CO2. So I'm breathing extra oxygen in than I need. Okay, that's fine. Because I'm basically breathing to get out CO2, and in the process I get all the oxygen I need in the process. So in the normal circumstances, you hear the term, people are on CO2 drive. And that is because it takes more breaths to get out the CO2 than we need breathing in to get in the oxygen we need. All right? And who is in charge of breathing? Who tells you to take the next breath? Now, where it happens is your lungs. How it happens is your chest cage and your diaphragm, but who tells the chest cage to expand and the diaphragm to go down? And that is the brain. So the brain is in charge of breathing. The brain is the most sensitive organ to breathing. All right? And the brain's going to instantaneously know when there's a problem. All right? So we're going to move on. These are the key points. All right? I wanted you to pick up. And I'm going to add in a few more points that I want you to pay attention to. Let me get my little cheat sheet to write these down. So, first thing is, we're going to talk about pH. So we understand that CO2. All right? So, pH equals the negative logarithm. It's not as bad as it sounds to be playing math right now. Log is base 10. So what does that mean? Well, what is 10 squared? It's 100. So what's the log of 100? It's the exponent 2. Log of 1,000 is 3. It's also how many zeros? So the negative log would just be the negative log in this case, let's say a pH of 2, is 1 over 100. So you just flip it. That's all it means. Well, why do we even talk about this in breathing? Water is H2O. We are mostly water. Another way to write water is HOH. Just two H's is an O, it's the same thing. In chemistry, we put arrows, not equal signs, and we put arrows in the direction that things tend to go. In this case, I'm going to leave it arrows equal. I'm not going to get into which way it wants to go. But water breaks up into an H ion and an OH. So there's one O, there's two H's. There's a net zero charge here, plus 1, minus 1, net zero charge there. All right? So why do I write this? That's because of this guy. Hydrogen ion is by definition acid. Hydrochloric acid, HCl, breaks into H plus and Cl minus. Phosphoric acid, H3PO4, breaks into H plus H2PO4 minus. Sulfuric acid, H2SO4, breaks into H plus HSO4 minus. So that H plus is acid. And anything that has a lot of H's is acidic, and anything that takes away a lot of H's is basic. And how do we define that? Well, we decided pH of 7 is neutral. All right, what does that mean? Again, that negative logarithm whole thing. That means water is the definition of neutral. So if water, we measure the number of H ions. If you have more H ions than water, you are acidic. If you have less H ions than water, you are basic. Well, how many H ions is that? Well, pH is 7, negative logarithm. That means, well, that's not going to be seen well. We had that issue yesterday, so let me get back to a dark color. 1, 2, 3, 4, 5, 6, 7. That means for every 10 million water molecules, one of them has done this. That's what a pH of 7 means. For every 10 million water molecules, one has done this. So if you're putting out more, so a pH of 6 means 10 hydrogen ions for every 10 million. You cancel a 0, you cancel a 0, you got 6 zeros left. There's your pH of 6. If, on the other hand, you go pH of 8, well, then I'm adding a 0. 1 out of every 100 million. All right? So we got to understand pH because it gets into why we breathe. This is really annoying to be sitting here going, I thought I was going to learn why I breathe, and you're talking about all this acid stuff and water and pHs, and man, this is annoying. But you have to understand the concept of an H ion and creating it or getting rid of it. Because this next formula, so the formula for, all right, CO2. That sounds really weird. All right? Water, we said by definition is neutral. By definition, it is neutral. If you have more H ions, acidic. If you have less, you're basic. Plus carbon dioxide. Carbon dioxide, I don't see any H ions. So that's neutral. Now, does carbon dioxide dissolve in water? It's a very key concept. Does carbon dioxide dissolve in water? You're a water-based system. Blood goes down to your toes. Oxygen goes into the cells. Carbon dioxide comes out. Carbon dioxide goes back to your bloodstream, your water-based bloodstream, to your lungs where it's exhaled. Does it dissolve in the water coming up to your toes? Well, whoever drank a Pepsi or a Coke or a Fanta or a root beer, what's the number one ingredient? Carbonated water. So all of those bubbles of carbon dioxide, how many bubbles come out of your soda? Carbon dioxide readily dissolves in water. So again, those arrows are not going to emphasize size of arrows, which it goes, but that combines to form H2CO3. So 2 H's, 1 C, 3 O's. And here is the kicker. Carbon dioxide, when it reacts with water, makes carbonic acid, which makes acid and bicarb. And so when I exhale CO2, I am running this equation in reverse. I'm taking bicarb, neutralizing the acid, making carbonic acid, making water CO2, and bye-bye CO2 when I exhale. So when I exhale, I am getting rid of CO2, which is getting rid of acid. So why do I breathe? To get oxygen in and get rid of acid by getting rid of CO2. That is critical. Your second to second, minute to minute control of your acid-base status in your bloodstream is done by breathing. If I need more acid in my bloodstream, I need to raise it, I just hold my breath. If I need to get rid of acid, I breathe more rapidly. My hour-to-hour, day-to-day, week-to-week control of my acid-base status is done by my kidneys. My kidneys run this equation and they go, okay, we'll take some carbonic acid, we'll filter it into the urine, and wait, let me see, am I acidic? Yeah, I'm acidic, so I'm going to take the bicarb, put it back in the bloodstream and pee out the urine, pee out the acid. Oh no, wait, I'm too basic, so I'm going to put the acid back in the bloodstream and pee out the bicarb. So your acid-base status is primarily controlled by breathing, but is backed up by your kidneys. That's very critical. All right? So, understanding this formula and that whole concept of acid and the pHs. All right? So, now we start applying it clinically. So, what's the worst that can happen? So, if the worst that can happen, if I am not getting enough oxygen in, for whatever reason, I am not getting enough oxygen in, what's the worst that can happen to me? And how quickly can that happen? Put a plastic bag over your head and see how long you last. This can happen in front of you. The patient that is hypoxic can die right in front of you, and you can treat it. They're lacking oxygen, give them oxygen. If they are breathing on their own, making that effort, and able to move air in, they're using your non-rebreather or your nasal cannula, depending upon how bad it is. If they're not breathing on their own, get that BVM out and breathe for them. If they've got an obstruction, do that Heimlich or abdominal obstruction. I don't have to say Heimlich anymore. Or you're doing that intubation, you're putting that NPA in, you're putting that J-tube in, you're intubating, you're doing a crate. All right? One of the 4 major causes of death on the battlefield in trauma is hypoxia. So these people would die in front of you, and you had better recognize it and you better treat it. What's the worst that can happen if their CO2 is not managed? If they're not breathing out enough CO2, they're building up CO2 in their system, they're building up acid in their system. What's the worst that can happen? How quickly do they die? Diabetic ketoacidosis is going to take weeks. This takes days to weeks to develop and kill you. If they happen to die in front of you, they've been dying for a long time. So if someone has an oxygen deficiency or is to excess, and they are capable of trying to solve their own problem, they're going to show up with rapid breathing. Right? They're going to be tachypnic. The question is it just because they ran into your clinic and they were late for their appointment and give them a moment to catch their breath and they'll be okay? Or is there something clinical you got to jump on top of? And if you don't jump on top of it, they're going to die in front of you, all right, because you're not recognizing they're potentially hypoxic. So these are reasons that people breathe fast. So tachypnea. People breathe fast because they're hypoxic. Acidotic. And here's a little curveball. They're emotional. We call this the hyperventilation. Classically, the whole brown paper bag thing, you know. So someone who's hypoxic is going to breathe fast. Someone who's acidotic is going to breathe fast. Someone who gets an emotional stress is otherwise normal, but because of the emotional stress is going to breathe fast. In the process, they're going to breathe in way more oxygen than they need. No big deal. They're going to blow out way too much CO2, which is going to make them lightheaded, tingly, stuff like that. And what's the worst that can happen to someone who's emotional and hyperventilating? They pass out. Do the funky chicken. Pee on themselves. And then wake up. So someone who hyperventilates and untreated, they're going to pass out. They're going to do a little jerky. They're going to have a little mini seizure. They might pee on themselves. They're going to breathe normal, wake up, and be fine. Got to change your drawers. So as long as they don't hit their head on the way down, they're fine. The big question is, how do you tell the difference? All right? And so the next question is, how to tell the difference. How do you tell the difference between these three? And the answer is, you stab them in the wrist, you draw out arterial blood, and you go to a machine, and you squirt the blood in, and you wait to see what the machine tells you. Without that machine, there is no way to tell. It's an arterial blood gas. Without an arterial blood gas, there is no clinical way to tell. All right, to be definitive, you can highly suspect, well, you just got chest trauma, you got a sucking chest wound, I put an occlusive dressing, I hear decreased breath sounds, I can assume you're having hypoxia issues. All right? And I can go ahead and treat that. All right? Very logical. But the only way to definitively tell, especially in a medical setting, is with an AVG. So since I don't know which one it is in someone who is tachypnic, how do I treat an oxygen deficiency? You give them oxygen. How do I treat a CO2 excess? Well, they need to go to the doctor and get fluids and potentially dialysis and things like that. Things that we're not going to do out in the field, we're not going to do in the clinic. We got to get them to the hospital, so these people just need transport. If you give these people oxygen, you don't help them, you don't hurt them. If someone is emotional and hyperventilating, and you give them oxygen, it might calm them down emotionally. It's not going to help them per se, it's not going to hurt them. But if you withhold oxygen, this person dies, doesn't make a difference, doesn't make a difference. If you give a paper bag to somebody who's hypoxic, you kill them, you help them. So since you can't tell, someone who's tachypnic, it's oxygen to proven otherwise. Straight up. You just got to make the decision. Do I need to do any advanced airways? Can I just put a face mask on them, non-rebreathing, nasal cannula, whatever? But that's the question you have in someone that is breathing fast. All right? Which is the most common thing. Someone comes in tachypnic. All right? Slap oxygen and then figure it out. All right? So, the next half, or the next piece, take that away. Is breathing slow. Let me just make sure there's nothing else I want to hit. Okay, so someone is, I don't know how to pronounce it, but it's tachypnic. I am sorry if the spelling is wrong. Like bradycardia, bradypnic, tachypnic is fast. They're breathing slow. So someone who is breathing slow, what's the first thing you assess? What's always the first thing you're going to notice and assess in everybody is their mental status. So has anyone here ever breathed 0 times at a rate of 0 times a minute? No one's ever swum underwater. Swim underwater, while you're underwater, you're breathing at a rate of 0 times a minute. But you have a normal mental status, you come out, you're having a good time, but when you come out, you catch your breath. All right? But there are times when you might be taking somebody's respiratory rate and it just happens to be low. But they have a normal mental status. And since they have a normal mental status, that means their brain is in charge. The brain controls their breathing. The brain is saying, I only need to breathe 8 times this minute at a rate of 8 times, so I'm fine at that. No treatment needed. But if they're not fine, if they have an altered mental status, what does that tell you? It tells you 2 things. One, they're trying to die because they're not breathing, and you better breathe for them. But 2, who is in charge of breathing? The brain. Is the brain working? Clearly not. It's got an altered mental status. True story, I was an EMT in New York City, as I said earlier. Got called to this apartment by the mother. Son was acting goofy, now passed out on the floor. A early 20s, slender, muscular-built gentleman, all right, needle by the side, kicked the needle away, took a pulse and a respiratory rate when my partner did blood pressure. I did both for 30 seconds. In this simultaneous 30 seconds, I was able to get respiratory rate and pulse. Got in the 30s, so pulse rate was in the 70s. I got 2, respiratory rate was 4. In an unconscious person, I immediately opened the airway, dropped an a J tube, and started bagging him. My partner got a blood pressure, it was normal. I bagged him the rest of the way to the hospital. We get to the hospital, the nurses start an IV, the doctor comes with this syringe, just stabs it into the IV tubing. Nothing's happening. Hit it again, the patient sat bolt upright, pushed the bag away, kicked the J tube out, looked at him, the doctor started to scold him, and the guy started to cry. He had a narcotic overdose, which is shut his brain down. His brain shut down, his brain forgot to breathe. He was dying in front of me. Luckily we got to him in time, breathed for him. He was given Narcan. Narcan blocks narcotics. He immediately had his reversal. It was very impressive. I was a young guy, seeing that for the first time. Very, very impressive. All right, so if someone is not breathing the normal respiratory rate, check their mental status. If the mental status is normal, you're done. If it's not, you're breathing for them and thinking, why aren't they breathing? What's wrong with the brain? Do they have trauma? Do they have drugs on board? So that's where your ample history or sample history becomes critical, because you're going to pick up information at the scene that you're bringing to me. And as medics, you carry Narcan, you're going to give the Narcan and see if that reverses whatever's going on. But it may be that they had a head injury and their brain is swelling and it's herniating and it's shutting off the respiratory center. And until we can get in there and relieve that, you've got to keep them alive by breathing for them. All right? So, in summary, the brain is most sensitive, brain is in charge. You breathe to get O2 in, CO2/acid out. If you are breathing fast, the question is, are you hypoxic, acidotic, or emotional? Since you can't tell the difference, you always err on the side of saying hypoxic and you give oxygen. Don't get into this thing about, well, people are on CO2 drive, they're COPDers, and they're CO2 drive, they're CO2 retention, and if we give them too much oxygen, we're going to shut it down. That's when they're feeling fine, but not when they're going, because they just popped another bleb, and now they've lost lung capacity, or they're having an asthma exacerbation from their COPD, and they're not getting enough oxygen, and you need to up it, because now they're in distress. So anybody in distress is tachypnea, gets oxygen to proven otherwise. All right? So throw out that concept that everybody's CO2 drive, and if I give them oxygen, I'm going to shut that down and they'll stop breathing. If they stop breathing, you're going to breathe for them and give them oxygen anyway. All right? And then you have the people who are breathing too slow. Check the mental status. Mental status normal, you're done. Mental status abnormal, breathe for them. all right, and figure out why their brain's not working. All right, so those are the key points from this one. Took a little longer. Sorry for the math. And I hope to see you next time. Don't forget to hit the subscribe button, all right, so I can become a rich, wealthy guy off of these little lectures that I'm hoping to help you with. All right, out here.